we're really excited about partnering with Charm on RPM for this and making this available to you. And we hope you find today's presentation and discussion to be valuable. What I thought we would do today is first talk a little bit about what RPM is and its new sibling program, Remote Therapeutic Monitoring, or RTM. Discuss the impact of RPM that can have on your patients as well as costs. Discuss the current RPM offerings that are out there, some of their drawbacks, what our company Helios does and how that addresses a number of problems with RPM, the financial impact RPM can have on your practices. Wrap that up with what makes a program fail and succeed, and then open this up for questions. So let's go ahead and get started. So first, a little bit about us, and we had a great introduction. Helios is an RPM orchestrator. What that means is that we offer an end-to-end RPM solution. We select the hardware, the software, the services from dozens of companies in the market to provide a tailored solution to all of our clients. We're vendor agnostic, so that we represent our providers rather than a particular hardware or service company. We're not tied to any one vendor, but have relationships with many of them. We've been doing remote patient monitoring for close to 3 years, which in this industry is quite a bit because it's only about 3.5 years old. We've helped develop RPM software, RPM hardware, and RPM service offerings, and have implemented numerous RPM engagements, even for single provider offices. So we think we bring a good perspective and a breadth of experience to today's discussion. So, but what is really RPM? Most of you know this, but I think it's important to get a clear definition since the RPM industry is very young and has been changing quite rapidly. But at its simplest, RPM consists of the patient who utilizes a medical device, and it's important. Medical device is important because it can only be a medical device. Outside of the four walls of a health facility to better manage their health condition. The provider, who uses patient data to monitor chronic conditions, primarily diabetes, hypertension, CHF, and COPD, although there's other conditions that are being able to be monitored as more innovation occurs. And then the hardware and software to automatically transmit the physiologic data from the patient and display it in a usable manner. Think of this as a care model that provides healthcare professionals with more frequent, actionable patient data, which improves patient outcomes, lowers costs, and provides a substantial financial incentive to providers, their health systems, and to payers. So how does that differ from remote therapeutic monitoring? Well, RTM is brand new this year, and there is a little bit of confusion as to what they are. But by definition, RTM is a collection of therapeutic, non-physiologic data collected via a medical device or software as defined by the FDA. Such data can include signs and symptoms and functions of a therapeutic response related to respiratory system status, musculoskeletal system status, therapy adherence, and therapy response. How does remote therapeutic monitoring and remote patient monitoring differ? The type of data collected in sort of 3 different ways. So the type of data collected first. Therapeutic non-physiologic data is RTM, and physiologic data is RPM. The manner in which the data is collected. So RTM data can be self-reported, whereas RPM data must be digitally recorded and transmitted. So that's a big fundamental difference between the two. And it allows you to collect data on the patients who can just enter it into a software program. And finally, third, the ability to bill for such services. Non-physician providers such as PTs and OTs and PTAs, as well as even dietitians, can bill for RTM and are eligible to bill for it, as opposed to RPM, which doesn't permit that. So what is the impact of RPM on patients? Well, one of the publications that we like best for this is the Network for Excellence in Health Innovation Survey, which looked at several different RPM case studies and pulled those results together. And what it found was that patients who engaged in RPM saw a 60% reduction in readmissions in the hospital, 460,000 to 627,000 potential heart failure readmissions prevented each year, and a net savings for those patients who use RPM of $5,000 per patient per year versus the standard of care. And this is one of the reasons why RPM has become so big. Now, these studies were done over a dozen years ago. So the impact today is even larger. In addition to that survey, we also liked a case study done by Centura Health. They followed 200 patients for a year, and what they found was that hospitalizations were down 62%, readmissions were down 65%. And what I think is even most impressive was that emergency department utilization dropped by over 90%, from 283 visits the year before down to 21. And then lastly, Biden Health. They followed 1,300 patients, and over 3 months, they were able to see similar drops in hospitalizations from the other two, but also had a 99% patient satisfaction. NRPM also lowers costs. So that same NEHI survey estimated that there was around $6 billion in cost savings for hospital readmissions for heart failure alone. Biden Health saw a 68% reduction in hospital costs. In the case of Christus Health Plans, they had an ROI of 144% over 5 months, and as well as a 90% reduction in their costs. And then lastly, Lee Health saw a savings of $5.3 million. So the cost savings are pretty obvious as well. Now, those were very large organizations. So let's look at this from a much smaller group. Now, this is a client of ours with around 40 providers, and they were across 5 sites. It started an RPM program just last year. And what they saw were significant changes in medication, such that in the first full month, over 50% of the patients required who were on the program required a med modification. And a third in month 2, and then a quarter in month 3. So of all the patients who participated, 50% in the first month actually needed a medication modification. That's significant impact for their patient population. At the same time, office visits also increased among that population by 14% in month 1, 27% in month 2, and in month 3, 17%. Financially, they were able to code $124 per patient per month in month 1, through RPM, $131 through month 2, and $134 per patient per month in month 3. So pretty substantial revenue numbers as well, based on those populations. And providers we find are always concerned about whether patients are going to like RPM and how it's going to affect really your relationship with those patients. In another very recent case study from a vendor of ours, the patients were asked, overall, how satisfied are you with remote patient monitoring? Over 90% in this case were very satisfied or satisfied. And in fact, in all of the studies that we've looked at and case studies that are out there, satisfaction generally is 90% or higher with remote patient monitoring. And they were also asked, since the beginning of the program, how do you feel about your healthcare provider? Almost 2/3 said that they felt more connected to their healthcare provider. Now, these are providers that have an inpatient practice. So as you can imagine, if you have a virtual practice, as many of you do, the increase that you're going to see in terms of feeling more connected and satisfaction is going to be tremendous for those people who participate in your program, who don't get to come in and see you on a regular basis. I think one of the interesting insights is as we've increased the use of technology, certainly in medicine, it has really put itself in many cases in between the patient and the provider. RPM, I think, is one of those very few innovations on the technology side that's actually helping to bring provider and patient together. And I think that's very encouraging. However, even with all of this great cost savings and satisfaction and the rest, RPM, for the most part, just hasn't been living up to a lot of its hype. And I think here's the problem. This is a new industry. It's 3 years old, and the solutions currently being offered aren't matching the needs of the provider. So most vendors out there will sell an RPM software package, maybe some hardware, and then dump it into the hands of a healthcare provider and expect them to be able to do it. We all know doctors' offices and healthcare systems. So if we take a second and think about it, can you imagine evaluating the dozens of blood pressure cuffs, scales, and glucometers that are out there, being able to handle the supply chain around each one of those, including the warehousing, the tech support, the connectivity, the fulfillment of each device? Now multiply that by 1,000 patients across your practice. Plus, you have to develop all of the monitoring processes and procedures from scratch with a staff that has no experience and is already stretched. I mean, the reality is that most likely, most of you have none of these capabilities. And we see that over and over and over again with the practices that we go to. And even more broadly, with insurance reimbursement having been flat or declining for years, the financial resources are extremely stretched to be able to implement a program that can be quite expensive to get started. So of course, RPM is going to fail if that's your solution. And what we've seen is that these do-it-yourself type RPM programs really underperform. They lead to unhappy patients and disappointing financial results. Drew and I have witnessed this all occur repeatedly across a wide range of sophisticated clients. RPM has far too much positive potential and should be successful. So with that, I'll turn it over to Drew to discuss this further.
Thanks, Matt. So currently, providers don't have the time, knowledge, experience, or personnel to run an effective RPM program. And this is not a knock on providers. This is, RPM programs can be very complicated. What we're often seeing in discussions about RPM is you take some devices, you put them on patients, you make sure those patients are they're healthy and they're within their thresholds, and everything works well. And that's just not reality. Successful RPM programs have a significant number of components that need to be handled, and that is what this slide illustrates here. So these are all of the primary large bucket tasks that need to be handled in order to successfully run an RPM program. Next slide, please. So providers, right now, if you're a provider, you're obviously doing patient care, you're doing your billing, you're doing your coding, and adding RPM into that workflow is not a problem. It's all the other stuff outside of that is very different from what you're doing today. Next slide. What we see with most RPM providers, third-party RPM providers, is they are providing what we call a DIY or do-it-yourself solution. They provide a solution to the providers that includes robust software, tech support that goes along with that software, some level of EHR integration, and that's something we aren't going to spend a lot of time on since it can be very complicated. Devices, usually a marketplace where you can buy your own devices, some type of fulfillment, and then providing coding information that you can use for billing. And that's really mostly what is offered out in the marketplace today. And this is what is expected, that providers are expected to fill in all the other holes. Next slide. So what we found is, in order for as providers to have a successful RPM program, they need help with all of these different areas. And I'm going to go through quickly kind of what these areas are and talk a little bit about why this is not in your typical workflow currently. Next slide. So the yellow area is where Helios spends a ton of our time. We help with patient enrollment, patient recruiting, the engagement, and the retention. And that all leads to much better healthcare outcomes, along with much more successful on the billing side and the reimbursement side. We bring the enrollment staff, compliance staff, get all of the proper consents in place, and make sure to monitor all the measurements that are coming in from the patient and triage those alerts. Next slide. We also pick and choose the best software package that will be the best fit for the provider. And that comes with top-line tech support. We make sure to train all the staff anyone that is involved in the program on that software. And then there's some level of EHR integration. Now, again, that can be very complicated. EHR integration can go from mass uploads of PDFs to discrete data being pushed back and forth, and that's specific to each EHR and the different versions of EHRs. Next slide. We also bring all the devices to the table. So we go out and try to find all the devices that we feel are the best devices. Right now, we only do cellular devices because cellular devices are much better for the Medicare population that we are focused on. Cellular devices are simple. They work out of the box. There's no Bluetooth pairing. There's no wall warts that you have to connect to at the beginning. It's just very straightforward. They pull these devices out of the box, they hit the button, and they go. We feel that one of the biggest hurdles for a lot of particularly primary care doctors is that major upfront cost, and we try to reduce that as much as possible. And that's why we provide those devices as part of our service and within the regular services that we offer, instead of having the provider needing to buy all those devices up front. We fulfill those devices automatically to the patient and manage those devices, whether that's tech support or training with the patient. Next slide, Matt. Then one of the areas that is often overlooked with an RPM program is the upfront project management that happens. And that's setting expectations not only with the RPM provider team, but with each individual provider, that and making sure that they understand the value to their patients, the value to their panel, the value to them in particular. We also work with that provider on making sure they are able to convey to their patient panel the value of this program and sell them on why they should be doing this. In the end, we're giving the providers much more data that they can help these patients have better healthcare outcomes. And we want to make sure everyone understands how this works and help get everyone on board and working on this together. And finally, we provide all of the coding information needed for the billing department. We do not do billing and we do not do patient care. So what we have found is every group that we've talked to, they are already doing their own billing. They don't want us to touch their billing either. We provide them with all the information they need to do the billing. So what we have tried to provide here is a full service RPM program that does not disrupt the current flow for a provider. So this is within their current workflow and their staff. We don't want to overwhelm staff, which is already usually overwhelmed anyway. So this is no more burden on staff or the provider, and we do it all. The only things we don't do are patient care, which is what providers do anyway, and we don't do any of the billing. And now I want to turn it over to Mike, who is going to go through the platform and some of the specifics within the platform that we use.
Thanks, Matt. Thanks, Drew. Really appreciate you guys letting me be here with you today. So as a preferred partner of Helios, I'm going to give you an overview of the software that Helios would be using to manage patients and manage your patients. And in particular, we developed our RPM software to partner with companies like Helios because we realized there were holes in existing offerings in the marketplace. So with our patient engagement expertise paired with Helios expertise, we applied that to the RPM model, which I'm going to walk you through today. So what does that model contain? Well, obviously things like Matt and Drew went through, activating those devices, defining the thresholds at a patient level, at a provider level, even at an entity level. And a threshold can be X for blood pressure, Y for weight. We'll talk a little bit about interventions here and some upcoming slides, selecting those devices, provisioning those devices, prescribing those devices, reviewing that device information. There is a lot of data that comes back into the platform, and that data must be actionable. Proactive interventions, as I just mentioned, and then data exploration. So next slide, please. Okay, so what you see on the screen right now, and I'm just going to give you a brief overview here of what you're looking at. So this is patient Kenneth Barak. This is the actual dashboard portal that Helios uses to manage their RPM patients, i.e. your patients. So they will see all of the information about the patient, any patient ID, any types of interventions, any devices the patient is on. Right in the middle of the screen, folks, those bubble icons that you're seeing, that is actually a patient journey. And what that is every digital communication that has gone out to the patient. Those are patient responses that have come back in through various digital channels. That could be an SMS channel, that could be an email channel, that could be an interactive voice channel. Okay, so going over to the left-hand side of the screen, Helios would see all of the patients within your practice that are currently on RPM, on a specific device, specific disease state, etc. Over to the far left is really the master kind of navigation. All right, waiting rooms, yes, there is virtual visit capabilities built into the software, any type of queuing, push-pull to certain providers, certain entities, certain people within Helios. Messaging, I'll show you a little bit of that upcoming. Helios has the ability to communicate with your patients over a variety of those digital channels. And then, of course, to interventions, which we're going to cover here in a second. Next slide, please. Now, this kicks off with, and we're going to use the example of hypertension and weight management for right now. It's you provide a list of cohorts to Helios or patients that you've identified that are hypertensive, and they need to be on this particular program. You've recommended them for RPM. The types of communications that will go out from the platform when a patient has been identified, Helios places them into the platform. Over on the right-hand side, what you're seeing is a simple communication to the patient. It's giving them some information about hypertension. We can let them know, hey, your provider has recommended that you be on a particular BP cuff, for example. The patient can easily just say, hey, structured response. They can click, yes, I am interested. And again, you see that patient journey in the middle of the screen, any communications that go out to the patient, whether automated, whether done by Helios, whether that comes back into the platform. Next slide, please. This is an example of another communication in an SMS. Hey, Jackie, as part of that hypertension weight management program, please review the objectives and the details of the program here. So what we're doing here, folks, is we're utilizing digital combined with the Helios team. We're serving up relevant information to that patient to reach out and say to them, hey, this is reinforcement of why your provider recommended that you be on a particular device, you be on an RPM program. So we're serving it up to them. We're making it, we're utilizing communication that is easily digestible for the patient. And go ahead to the next slide. So we get the patient. They say, yes, I am interested. Absolutely. I realize that I need to be on a particular device. I realize that I need to be enrolled in this program. And we are going to enroll them digitally. They can review, they can sign any type of a consent form. Again, we're reinforcing what is the benefit to you. Why should you be on this particular device? Why should you care about managing your hypertension, whether it's risk of stroke, any number of things that they need to know? We're serving up that reinforcement. They can digitally consent, and off we go. Now the patient is enrolled. Next slide, please. Okay, we're back to Kenneth. We're back to Kenneth Barak here. And as you see on the screen, Kenneth already has a couple of devices registered to him. But what we're going to do here is the Helios team can say, okay, let's prescribe them a blood pressure cuff, for example. So that button over on the right, the Helios team would click there to prescribe an additional device to Kenneth. Next screen. They can select from a list of devices that are loaded into the platform that are specifically for you guys, your entities, your practice, your clinics. Helios folks can easily select a device. From there, they're going to see, go ahead and click, all of the information about the device. They're going to put in that IMEI number, which is essentially tagging it to, as Drew had mentioned, cellular service. They can put in an activation date. When is this patient going to be active? They can also put in an end date too. So I'm walking you through the process of prescribing a device, i.e. provisioning a device. This is what the Helios team would go through. Next slide, please. Now, this page is very, very important. The Helios team will utilize what you're seeing on the screen right now to set those thresholds that I mentioned earlier on in the presentation. Whatever those thresholds may be, maybe it's blood pressure is X, weight is Y. They can combine multiple devices together to cross-reference and combine various thresholds. So if a patient does not meet a particular threshold or they exceed a particular threshold for one or more devices, an intervention would be created for that patient. Well, I'm going to walk you through that here in a second. But the trigger page is very important. And this is walking you through the functionality that Helios will use to facilitate that clinical intervention or that Helios team intervention when and if it is needed. Okay, so the device is set up. The device is shipped out to the patient. Now we know it's arrived. It got shipped right out of the platform via API. The patient receives the device, and over here on the right, here's an example of the patient getting a weight scale. So what we do, we will serve the patient up with some timely information. We will send them an email or digital communication with a simple link, and this is an educational video here. This is how to set up that device, specifically what it does. And they can rewind, they can review, they can watch it as many times as they want. The goal here is, folks, is in the RPM world, it is very, very, very important that first reading, getting them comfortable with the device, we want to make sure that they have the education that they need at their fingertips to get that device activated and get them going on the program. Okay, so let's go back to Kenneth. All right, and let's go ahead and we're going to talk about some interventions here. Okay, so Kenneth is on blood pressure monitoring. He's got a cuff. And as you see, again, let's go back to the middle of the screen. You see that patient journey? So Kenneth took his first reading, he took his second reading, and somewhere along the way, he exceeded one of those BP thresholds, okay? And that threshold, again, can be set at the patient level. It can be set by, the provider determines what the level is, whatever it may be. An intervention came about. Kenneth needs assistance. Next slide, please. So all of this data is going to be at the fingertips of the Helios team. They're going to see everything that went on with Kenneth, what communications went out, what were Kenneth's responses, what came back in, and obviously the device data. So the Helios team is going to be able to analyze, let's look at his historical, let's look at his blood pressure data, what is going on with Kenneth. Helios needs to be able to slice and dice every 6 months for a year, whatever it might be. You can go ahead to the next slide. Okay, and again, slicing and dicing the data, making it actionable for Helios to be able to get involved with the patient and make sure that that patient is taken care of. Next slide, please. And that intervention, the Helios team will have at their fingertips to service your patients. Of course, they can call, put any notes in the system. They can send an email to the patient. They can communicate via two-way SMS with the patient, or they can share this with the provider in a HIPAA compliant fashion outside of this platform via a one-time passcode framework. Many different options to communicate with the patients and or communicate with staff should that ever be necessary. But Helios is the main facilitator of what you're seeing right now on the screen. And any and all communications are timestamped and they're absolutely categorized for billing. Next screen, please. Okay, so this is an example. We've dealt with an intervention. Kenneth gets back on. He's totally compliant. He's taking the readings when necessary, when he has to. This is an example of a nurturing message. We want to keep Kenneth engaged. We want to keep him involved, okay? By keeping him involved, reminding him of why he is on RPM for a hypertension program. This is going to lead to better health and engagement for that patient, and in turn, higher reimbursements for you folks. Next slide, please. Okay. Thank you.
All right. Well, thanks, Mike. Appreciate it. So I think one of the key things to keep in mind about software in particular is that it really serves a couple of functions in most cases. Number one, it captures the data. Number two, it makes the data available for you as a provider to be able to see trend lines and see how a patient is doing over time. And number three, it alerts the staff, either the Helios team or your team, about when there's an issue that may arise as it relates to with a patient. So if their blood pressure is high, if they have congestive heart failure and their weight increases rapidly, if their glucose is out of whack. So in any of those cases, that's what software does. What we really like about Patient Bond in particular, and like I said, we evaluate dozens of software. What we love about those guys is they take it to a different level. And the level that they take it to is that they help you engage your patients much, much more so to keep them compliant, to keep them retained, and to keep them enthusiastic about the program. And they're very unique that way. We've never seen anybody else do what they do in that regard. And it's why we like partnering with them in particular. So now let's spend a little bit of time on, in this case, on CMS, on reimbursement. So in addition to providing that actionable data to your patients, what's the financial impact of RPM for a practice? I'm going to be focused in this case on a Medicare environment, since this is the most consistent across the country. Private insurance in many geographies is now covering RPM, especially over the last couple of years, which has been great. And it can be significantly more lucrative than CMS, but it varies significantly by plan, by payer, by geography. And so for this instance, we're going to look at CMS. And there's 4 codes for RPM, and they also mirror remote therapeutic monitoring as well, different numbers, but the same concepts. So the first code is 99453. This is the initial patient setup. It includes shipping the device, educating the patient, setting up the device on the cellular network, and this is a one-time charge. It doesn't even come close, honestly, to covering the costs of doing that, but it is a one-time charge as it relates to with RPM. The second code, 99454, 99457, and 99458 are all monthly charge codes. With 99454, generally it's around $55, and this includes monitoring by certified personnel. The cost of the device is included in here, the cost of the software, as well as the monthly cellular connectivity costs as well. So a lot is baked into that overall cost. And to charge that code, a patient needs to have 16 days of measurements, not just 16 measurements, but actually 16 days of measurements. If they only have 15 in a month, you don't get to bill the code. So keeping your patients very compliant is absolutely essential in order to realizing the revenue that matches the costs you've incurred, okay? So once again, compliance is very important here. 99457 and 99458 are both alerting codes. They're in 20-minute increments, and there must be some two-way synchronous communication, either through voice, video, or in person. That's why compliance, once again, is so, so important. You must interact with your patients regularly. You must have 16 days of measurements. You must have a built-in cadence for them, and you must reinforce that value to them to keep them going. And so you have to talk with them at least once a month. You also have to make sure that they measure 16 times. From a Helios standpoint, that's what we do. That's what our service provides. That's what we bring to the table is that we have standard operating procedures that enforce that and make sure that that happens. Our fees are approximately 50%, 50 of the total reimbursement. That's going to vary based on the level of service we provide and what we do when we build a solution for you. And remember, with the cost of the EHR integration, without taking out the cost of an EHR integration, there's zero upfront cost to a practice when they go with our company. So for those of you, though, who participate in a direct primary care model, as some of you do, or in a value-based care model, we also have alternative pricing. CMS has put many shackles, as you can tell, on providers in order to get paid. Those are all removed in those types of models. And so our services can be much more less expensive on a per patient basis. So let's talk a little bit about profitability. What does this all mean? So based on our experience, we find that the average primary care physician can have between 200 and 400 patients who would benefit from RPM in the Medicare model. So they have Medicare Advantage or Medicare with a supplement, which means there's no copay. At $200, this would mean around $240,000 to your practice. And based on our fees, that's an annual net profit of around $120,000 per year, per patient. Per provider. At the higher end at 400, it's almost $500,000 in revenue and $240,000. Specialists such as cardiologists, endocrinologists, pulmonologists, nephrology, those types of specialties have higher numbers of patients who qualify, so they can bring in even more in terms of revenue. But if we take a look at a practice, let's say it's with 20 providers, 350 patients per provider, the annual revenue to the practice can be around $8.4 million and over $4 million in annual net profit. This can be a game changer for many practices. And that's why it's so important to look at RPM as a potential revenue source, but also an improvement in outcomes and in costs. And because there's no out-of-pocket, upfront cost, the return on this investment for you is truly infinite. So let's talk a little bit about why RPM, what makes it successful, and what makes it not successful. Why it succeeds. Number one, organizational buy-in. This just doesn't mean at the provider level. This is also staff. Looking at patients to be seen, seeing when they come in the door in the beginning of the day, identifying those patients who qualify for RPM. All of these are best practices, and identifying those good candidates and flagging them so that the provider can talk to them about RPM is critical. This means getting, when a patient leaves, you check to make sure that they are, whether they want to be part of an RPM program or not, and get the process started. But it has to occur up and down the organization. Rapid rollout. So this means rolling out the program quickly, going through a list of the patients that you currently have within your panel, reaching out to all of them who are eligible, and doing it in stages so that you start with a pilot program, especially in larger practices. Experiment, solidify those processes and the procedures that work within that group, and then expanding off of that. But the rapid rollout is critical because it allows everybody to see the success. It allows everybody to understand what the impact can be, and it creates adoption. It creates more readily adoption throughout the organization. Last on the success side is compliance. If you're not focused on compliance, your patients won't be either. So you have to have, you'll have a device. If they're not complying, you can't bill for, and a patient who gets less than optimal results. And so the secret to profitability and results really is making sure your patients are compliant and making sure they stay on the program for an extended period of time. And quite frankly, this takes a lot of work. It takes a lot of vigilance, but if you do it and do it well, the program will be successful. So here's why we see programs fail, and we've seen this quite a bit over the years. Number one thing, understaffed. As we've discussed, monitoring, enrolling, care triage, tech support, keeping patients engaged, all of those require a significant amount of staffing. What we found is the ratio from staff to patients is about 1 to 150. So in other words, If you want to have a program that works, if you've got, let's say it's 450 patients, you're going to need 3 additional staff members. For an office, we find around 5 providers, they're going to need 5 to 6 additional staff people if they do it themselves. That's what this impact can mean. So it's important that if you're going to take on a program like this and you want to do it yourself, be prepared to hire a significant amount of staff. No formalized processes are in place. If you don't have them, you're inefficient, and you can handle fewer patients, and your program is going to be less profitable. And quite frankly, there may be some errors, and it leaves you open for some liability. So it's very important to have those processes. And then lastly, poor patient engagement by the staff. As I've talked about before, engaging with your patients regularly, having a cadence with them when you reach out to them, all of that is critical. That's why, because of these successes and failures and what it takes, we developed at Helios an outsourced solution where we're able to do it all for somebody in a turnkey from the beginning to the end. We found that that's what's most successful. We worked hard at developing the processes in place to encourage compliance and retention and all those things. And just as an example, we have a client who we've done some work for who wanted to do it themselves. They have 17 providers and multiple sites in the Midwest. And after a year of doing it themselves, they enrolled a total of 16 patients. And the reason is because of these reasons right here: understaffed, slow rollout, no processes in place. And so therefore they didn't have a commitment and the program failed. So that's it. If you're interested, certainly, in hearing more about Helios and how we can help your practice, please reach out to me. I'm Matt at heliosmps.com, or you can check us out on our website, heliosmps.com. And at this point, we'll leave it open for some questions.
Thank you so much, Matt, Drew, and Mike, for your in-depth presentation, walking us through all the functionality and what the Helios team does, and how patient bond is involved in everything that Helios does, and helps Helios, how patient data is made actionable to Helios, and how Helios communicates it with the patient and provider as well. You also spoke about the CMS reimbursement and how it can be profitable to our practices. Thank you so much. With that, I'm going to pass it on now to our attendees who, if you have any questions, I know that many questions, there have been some great questions that have come through.
Sure, I've got a couple that that came through the Q&A that I wanted to have our team answer. One of them I'll start out with, and I can answer it myself, was talking about supporting other devices. So, and this goes back to sort of the model. So CMS has been sort of the driver of RPM over the last 3 years. And it's due to their reimbursements, and they have very strict limitations on the type of devices that can be used. And that's pushed most RPM companies that are focusing on that market into using blood pressure cuffs, weight scales, and glucometers, and sometimes pulse ox to go after some of the largest, most impactful chronic diseases out there, which would be diabetes, hypertension, chronic kidney disease, and congestive heart failure. And so that has sort of created a very limited number of devices that are being used right now. Now, what we have, what gets us excited is we are constantly looking at new devices. And those devices, CMS requires a medical, it has to be categorized in a cleared medical device. It has to be in that category. It doesn't have to be the specific device. But what we found is there are so many interesting devices and new technologies coming around. That's why we decided not to focus on just selling our own devices or having one vendor that we use. And so, we start looking at all of the new devices coming on, and we're ready for those. And that leads us to other models, as Matt had talked about a little bit, with direct primary care and value-based medicine. And we're excited to talk to providers that are doing work outside of that traditional CMS, those 4 disease states, and working with them on bringing on new devices that can really have an impact on the patient panel. So we're excited to talk to more groups about that. We have a lot in the hopper. We just don't have them online yet. But if you're interested in talking to us about an expanded view of RPM, we would love to talk to you. So that's an exciting model for us.
Yeah, and if I could just add one quick thing to that as well.
Sure.
So as it relates to devices, certainly if there's a device out there that you guys have that you want to incorporate into your practice and think it would be good for RPM, absolutely willing to talk to you about it. The gating factor in most cases is making sure that it can interact with various software platforms and that the data can be communicated. But what we're seeing in the market today is a huge effort by so many different device companies to take advantage of RPM because it can be very lucrative for them. And so they are really moving hard that way. In fact, Drew and I and Mike look at devices all the time, and we see probably one new innovation every single month where we get a demonstration on it. And so it's really changing rapidly. It's exciting. And I think you're going to see a lot more devices be available to patients.
Yeah, so we're working with. I mean, we see devices where they're just everything's on the phone, stickers, all of these different devices. So we're really excited about that and excited to talk to people about that. I think another question that Matt, I'd like you to just touch on a little bit is sort of the current state of RTM. There's a lot of conversation now about RTM, how that expands what used to just be RPM, and just briefly talk about that real quick.
Yeah, you bet. So one of the challenges with RTM is the final rule was issued for 2022 and was the first time RTM was made available. And there's a lot of ambiguity left in that rule that's been frustrating for a lot of folks as it relates to what works and what doesn't. With that said, it depends on how aggressive you as a practice want to be in terms of being able to bill for RTM. The key things around RTM, as I mentioned before, we're having a device, a medical device, and in some cases it's software, but allowing a patient to record everything from their compliance to their pain, to their flexibility in the world of physical therapy, and even in the world of, as I mentioned before, dietitians, just having somebody record their weight. Even though that can be done automatically, the dietitian can now take advantage of it. So it's really around therapy as opposed to, and it can be for long-term or short-term conditions. But there is still some gray area there. CMS has to, and we expect that they will by the end of the summer, initiate some changes to it. I think they're going to tighten some things up. But RTM is one of those areas where people are still waiting for a little bit more clarity before they dive in full bore on it. But there are, particularly in the world of physical therapy, that's one area where RTM is we're starting to see a lot of groups move that way. And it provides a lot of opportunity, as well as in the world of psychiatry, and psychology. So being able to treat some mental health conditions with some devices and therapy as how your mood is and those types of things, there's an opportunity there as well. And I think that's going to be taken advantage much more so as we go forward.
So we had another question come through that I think I'm happy to answer this. So the question is, do you work with providers who are interested in using their own staff, but your equipment and assistance with setup, consent, EHR integration, etc.? So absolutely. One of the things that we try that I think is important to convey to everyone out there is, model is not to come in and say, here's our box, this is what we do, you have to use it the way we tell you to. What we like to do is come in and talk with providers about what solution are they looking for. Do they want to use some of their staff? Do they not want to use some of their staff? Do they want full service? Do they just want part of the service? There's a certain level of service we need to provide to make the economics work. However, that's one of the things we pride ourselves on. There are lots of groups out there that can walk in and do RPM, and they do the basic stuff and they do it really well. We're a little different in that we want to find a solution that works for each individual group, and we try to talk to them about that. And we've had plenty of conversations with groups where we say, look, we're not the right group. You could use a different group that might be a better fit. And that's just fine with us. We really enjoy doing what we do and want to come up with a solution that's a good fit for, it's a good fit for the particular group that we're talking to. We might be talking to a system with 150 doctors, or we might be talking to an individual doctor. Very different needs, very different staff, very different infrastructure, and we have to modify our solution to fit that. So I think it's important to know that we're happy to have exploratory conversations with groups, talk to them about RPM, educate them on what we know, and then help them decide on what's the best fit for them.
Yeah, and I would add in one other thing. I think one of the advantages that you bring with going with a group such as ourselves, or with other RPM type providers, is that we purchase a lot of equipment. We purchase software seats and licenses, and we're able to get things for better pricing than an individual practice usually can. And that's part of what we bring to the table, as well as because of the way we do the services that we provide, we're able to also do those in a more efficient manner. We've spent a lot of time with a lot of clients developing our processes and procedures, and there's a lot of scars as a result of doing that. But that's where providers who come on board get the benefits of all those learnings. We look forward to at least having those conversations with anyone who's interested.
I see another question. The question is, how do you address patient resistance of RPM tracking as Big Brother? How do you communicate patient protection, especially if their stats are not trending in a good direction? A lot of that, a lot of the way we do that is we work with the provider on making sure that the provider is on board with the service that we're offering. They see the value in it, they want it for their patients, and they help communicate that to their patients. We can never have the same relationship with a patient that a provider has. That is the key relationship here. And if the provider feels that this is beneficial for the patient, it's important that they help convey that to the patient and understand that this information is for the provider and approved by the provider. So it really is the key. The key to this is the provider. Matt, do you have anything else to add to that?
Yeah, just quick to that is because of, we all know HIPAA, and because of the way HIPAA is, part of our conversation is around keeping that data absolutely sacrosanct to the patient and to the provider, and that's how the data is treated, so that it's to help the provider help the patient through their care. You do get resistance, and there's plenty of patients who do it. I think one of the greatest things that, and once again, this is why we partnered with a company like Patient Bond for a lot of this, and what they're doing, they're able to customize messages and communications to patients based on each individual patient's profile. So that with some patients, you're appealing to authority. In other cases, you're providing them additional information. And in some cases, like a patient who has a resistance, you're able to communicate to them in a way that they're more receptive to doing it. And I think that encourages greater compliance, greater adoption, and greater retention. And it's one of the most unique things that we've ever seen within the world of healthcare. But we're lucky to have a provider like it.
So I know that we're bumping up against time. There is one last question, and I can answer it very quickly. The question is, does a provider have to speak with a patient for 20 minutes in order to qualify for 99457, or can MA and staff communicate with patient via SMS or email in order to qualify? So the way that the 99457 and 458, which are essentially the same codes, there's 20 minutes of work that needs to be done with, and that can be reviewing the charts, that can be communicating with the patient in any way whatsoever. And it's really work on that patient's chart, looking at their data, looking at monitoring what the stats that are coming in. The key to that is, so there's 20 minutes that can be done. In that 20 minutes, there has to be some, and that's directly from CMS, some time of two-way synchronous communication. And the only things that qualify for that are phone, video chat, I'm sorry, video call and in person. So you have to do some time where you are conversing with the patient. SMS and email do not qualify for that, though the work can be done to qualify for the other part of the 20 minutes, but you still need that interactive time.
If anyone has any additional questions, we are more than willing to sit down and talk with you at any point with anybody just about some of these things and hopefully answer some questions, whether you are interested in doing RPM or not, interested in working with Helios or not. We are more than happy to do that. So please make sure that if you do have any questions, reach out to us. We'd be happy to have a conversation.
Thank you so much, Mike, Matt, and Drew, for your presentation on Helios's turnkey solution and how to improve the usability of our RPM service. A lot of really great questions that expanded some of our conversation here. And Charm is really excited to present this to our user group in this timely manner.